Well, Haas, as you know, it's one of the largest clinical trials, and in transplant, usually we come to the ATC posters. You gain insight and information, even if it's a single center study. So when you have a cohort of about 5,000 patients that are followed prospectively, longitudinally, obviously there's a lot of value, a lot of information that can be gathered. So it's something that I'm really excited to be part of, looking to a short-term and long-term analysis of the data as it comes out.
Thank you for joining us today. We're fortunate to have my dear friends and colleague, Dr. Yasir Qazi, the Medical Director of St. Joseph Heritage Medical Center in Orange County, California, with us today. He's going to share his thoughts and experience of implementing cell-free DNA Prospera in the surveillance journey. Also, he's going to tell us about how does he define high-risk patient in high-risk situation. And at the end, he's going to share his thoughts about the recent CMS article and how it has affected his practice. How are you doing, Dr. Qazi?
Pretty good. How are you, Haas?
Very good. The same here. We want to learn from your experience using cell-free DNA, since you have been one of the first physicians to start using this technique in your practice. Would you mind please tell us your experience about cell-free DNA and Prospera?
Yeah, of course. So Haas, as you know, overall, we've kind of struggled in getting long-term outcomes in patients who have received a kidney transplant. And with such a shortage of organs, it becomes important to have the motto of one kidney last forever. And historically, we've just relied on creatinine. And as a nephrologist, I always wonder, you drop in a kidney with 1 million nephrons, and how many nephrons do you have to lose before the creatinine goes from 1.2 to 1.3 to 1.4, and how much of that is reversible? So, we've sort of struggled in being able to detect injury early on, and especially injury that might still be reversible. So I've always been interested in whether a physical science, a urine analysis, whatever, to pick injury early on. So the incorporation of the technology of cell-free DNA, where you are able to identify, quantify, characterize early injury, is something that I feel like long-term may have an impact on our, to steer us right in the way we're probably managing these. So, it's been close to about 2017-18 when the technology got introduced, and it's been an evolution. You kind of learn some, watch some, teach some, and exactly. That's sort of where we've been right now.
Very good. I like your thought process regarding detecting the injury early on, so hopefully by intervening that you can reverse that. So it seems like you're using this test for surveillance and monitoring your patient. How has been the journey for you?
It's the journey is such a great word to describe this, because when I originally was in Buffalo, we did have a protocol biopsy. Again, we realized that we had to detect injury early on. We just didn't have the tools. So we were doing protocol biopsies where we were trying to assess the health of the donors, especially because one of the sites was a prednisone-free site. Mm-hmm. And we realized that even young kidneys with, minimum, had some sort of a minimal inflammation when they were steroid-free. So it became sort of a standard for us to do protocol biopsies. But then when I came to Los Angeles, it was a big challenge for two reasons. One, we had only a couple insurance companies that we had in Buffalo, so we had down with every insurance company. We had sort of come up with some sort of agreement. So the combinations of insurance companies in Los Angeles was, not possible. It was just creating a lot of work for the staff. Complicate that by the fact that a lot of our patients had been on dialysis for such a long time. They had comorbid conditions requiring them to be on anticoagulation. So to time it, take off anticoagulation. So protocol biopsy really became very difficult. So kind of went away from doing it until the technology came in, where we would then be able to, use it as a method to identify injury early on. And surprisingly, there were many patients where during the surveillance, the cell-free DNA was, strikingly abnormal, which sometimes we would not believe that it could be that abnormal because the creatinine had not budged.
Yeah.
Again, the thing that I mentioned, how many nephrons do you have to lose before you start seeing a change in the creatinine? And when we biopsied those people, when we repeated the test the second time around and was still abnormal, we biopsied them. To our surprise, they were like early injury, including antibody-mediated rejection, that we sort of would have totally missed. And like how much injury would we have missed, and how much of that would have been irreversible, right?
Very good.
So we were able to detect some of these things that we were absolutely able to incorporate strategies, therapies, monitoring of then the development of a DSA. I feel like if we had missed some of those things, we clearly would have had nephron loss, interstitial fibrosis, tubular atrophy, and to a point now, like some of these things are being revisited in terms of how we classify injury. So I think it, in my mind, at least for some of those patients, was a game changer. Right? We were able to completely sort of not only just identify, we were then able to risk stratify them as individuals who were going to be at a higher risk of having immunological issues.
Very good. You really read my mind, because your thought process regarding surveillance and monitoring all the patient, but having a different maybe way of monitoring the patient who are at higher risk. Who is those groups? Who do you consider high risk?
So it's a great question because the way I like to think about it or talk about it is high risk and high risk situation. I feel you could have a low risk patient that could end up being in a high risk situation. Correct. Because you've done radical changes in their immunosuppression, whether it was they had an infection and or they had leukopenia, that you reduced the immunosuppression substantially. If you don't continue to monitor them, they now became a high risk situation, right? So I like to characterize it as a high risk patient, clearly, which sort of like literature and history has taught us, somebody who's retransplanted, somebody who has a high PRA. I just got an organ offer this morning that was a slightly positive cross match, and whether if I took that, then I have a high risk situation, high risk patient on my hands. So we know some of those individuals retransplant, historically African Americans, but on the other hand, when you label some of these people, you may have wrongly mischaracterized it. So I like the concept of a high risk situation rather than just labeling somebody as a high risk. And to some extent, I've evolved my practice around it, where at the time of the transplant or subsequently, it's almost like a traffic light. I had a color code of red, orange, and green. So when I'm doing my lab reviews, I know this is, and it has a red dot on it, I know that this is a high risk situation on a high risk. So in my mind, I know that I have to run my immunosuppression higher. So I think because it's not a one size fit all, despite the fact that we would love to have everybody be on triple immunosuppression, because of the availability of technology to supplement the creatinine, I now have been able to individualize therapy a lot better. I have some patients that are on one immunosuppressive drug, and I have some patients that are on 4 immunosuppressive drugs because of their high-risk situation or condition that might require it to be monitored better.
I have a question I think is important, so I wrote it down before. I don't want to miss anything, so I'm going to read from whatever I wrote before. In the last few months, the Center of Medicare and Medicaid released a non-coverage update on multimodal assays and a billing and coding article specifically of performing and billing for labs. How did that update change your practice, and what do you think about that?
Honestly, I think it just requires better documentation of what the thought process was, because I guess initially people weren't putting it down to explain why it might be that a test is warranted or required in making the clinical decision making. From my understanding of it, it appears that you still have access to being able to manage patients in these situations. You just have to document and characterize it a little bit better on what it is. So for me, if I'm starting to see some abnormal lab values, or there's been a radical change in immunosuppression that I have made that requires a more detailed attention in terms of following a patient up, I need to explain that. I need to elucidate that thought process better to explain why I'm doing what I am doing. And again, it's something that is evolving. We're all obviously in the transplant community impacted by it, especially the ones that were early adopters of the technology, because it's kind of hard to go back once you've seen some of the benefits, as I described some of the patients that I know for sure benefited. But at the same time, obviously, we have to kind of do it right so there's no issues in terms of the management of these patients.
I'm going to switch gear and ask you about the proactive study. What is your thoughts around proactive?
Well, Haas, as you know, it's one of the largest clinical trials, and in transplant, usually we come to the ATC posters. You gain insight and information, even if it's a single center study. So when you have a cohort of about 5,000 patients that are followed prospectively, longitudinally, obviously there's a lot of value, a lot of information that can be gathered. So it's something that I'm really excited to be part of, looking to short-term and long-term analysis of the data as it comes out.
Very good. Yeah, we're very also excited to see what this study is going to show us. But we did the interim analysis, and I saw you at the poster session here at ATC in San Diego, and you were looking at our poster. What was your thoughts around these interim analyses?
So honestly, from me, it was, again, my theme's always been how do we detect injury, and you could see at some centers, the ones that had a bit of a delay from the time the cell-free DNA had gone up, or a relative change in the value, when subsequently they ended up having a biopsy, that there was evidence of both antibody-mediated rejection and T-cell-mediated rejection, which again characterized the importance of surveillance, monitoring, and detecting injury early on. And to me, the delay from the time of the injury to the time of detection can impact the reversibility of eventually bringing it back to normal function. So those are sort of like the interim observations from my, just looking at the poster and assessing and talking to other people.
Yeah, we are also very excited to see that, and we're hoping by following this patient longer term, we gain more insight about how does this cell-free DNA works. For the last question I want to ask you, there are physicians who have not used this technology as frequent as you, and they're thinking of implementing that in their practices. What is your advice for these physicians?
Again, the idea that we want to make these grafts last as long as we possibly can. I honestly feel that we've done a disservice by just being so focused as transplant centers on our 1 year and 3 year outcomes. I always am interested in finding out who has the best 20-year outcomes. So what do they do? What are their clinical practices? And detection of injury early on and using of therapies that may reverse some of these injuries become important to get to that goal of long-term good outcomes. So we have to be looking at things other than the serum creatinine, because as I say, time is nephron. And losing nephron mass eventually results in the deterioration of those allografts, and we know the folks that fail a kidney have the worst mortality of our ESRD patients. There are an enormous tax burden to the taxpayers, to the healthcare system. It's an absolute burden beyond what a patient or the individual goes through. So I feel folks that haven't used this technology should definitely consider it, and it will eventually move that needle in getting us to the long-term goal of one graft lasting for life.
Perfect. I know I said this is my last question, but another question came up and I totally want to get your opinion about that. You mentioned about monitoring this patient beyond the 1 year that a lot of centers doing. And as you know, many centers, they send these transplanted patient back to the general nephrology. So how do you think about general nephrologists using this technique and this technology of monitoring the patients with cell-free DNA in their practices?
I think it was sort of, we went through the growing pains because initially transplant centers were, themselves getting familiar with the technology. At least in Los Angeles, greater Los Angeles area, a lot of the community nephrologists are familiar with it. It just requires some sort of a crosstalk between the transplant center and the community nephrologist. So there is, everybody is on the same page. At the end of the day, we want to adjust immunosuppression based on these results. So as long as we at least at our center, we communicate frequently with the nephrologist on what is going on, and we sort of set that expectation out at the time we're discharging a patient back from the transplant center, in maybe elucidating what are the things that we're going to be requiring and for the long term on what our recommendations are, and obviously there's ways for them to access us based on what is happening. So these are things that we're still evolving, and I think in the next year, 2 years for sure, by the next 3 to 5 years, it'll be something that sort of, you might see a more standardized practice than what sort of is maybe an individual center practice right now.
Perfect. Thank you very much for your time. I hope you
Ross.
enjoy ATC. The same here, sir.
Take care, man.
Thank you for joining us. And don't forget to subscribe so you'll be notified regarding the amazing conversations that we're going to have with other primary investigators of proactive study.